Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at Home welcomes Professor Pierre Delanaye in Liège, Belgium, and Professor Hans Pottel in Kortrijk, Belgium, with whom we would like to discuss how best to estimate glomerular filtration rate, GFR, focusing upon their recent development of a novel equation for GFR estimation, the EKFC eGFR Cystatin C equation, which has been introduced a few weeks ago in clinical nephrology with a New England Journal paper. Pierre, Hans, thanks for being our experts tonight, and surely congratulations on your seminal publication in a leading medical journal.
Thank you.
So hello again from me too at Marcus at Home. We are so delighted to have you both. Dr. Delanaye is a nephrologist at the Department of Nephrology, Dialysis and Transplantation at the University of Liège, CHU Sarthe-Tillmann in Belgium. And the Dr. Hans Pottel is a senior researcher at the Unit of Public Health and Primary Care at Kulak Kortrijk campus in Belgium, which is a part of the KU Leuven. Dr. Pottel is the one who has developed this new equation, which we'll be talking about in just a minute. They are both leading authors of a very recent New England Journal of Medicine paper in which they introduced this new equation, as Professor Heine has already said, a cystatin-based equation for estimation of the glomerular filtration rate, which is called the EKFC eGFRcys. Our co-moderators today are the Professor Dominique Guerrot, who is the head of the Department of Nephrology at the CHU of Rouen, France, and Professor Gunnar Heine, who is the head of the Department of Nephrology at Agathon Markus Krankenhaus in Frankfurt, Germany. My name is Sarah, and I think I've said quite enough for now. I'll let the Professor Pottel continue and tell us more about this equation.
Thank you. So I will give you some background and history on the construction of the European Kidney Function Consortium equation, which is the abbreviated to EKFC, of course. And you know, or you don't know, but it all started with a pediatric equation. And we used the data from Amy Pieps from Brussels, who had done direct measurements of GFR in children, actually in children with relatively normal to near normal kidney function. And here you see on the left side the data that he presented in his original article in 2008. And you should focus on the P50 value, which are the median GFR values, but actually they are not corrected for body surface area. So they are non-corrected, they are expressed in milliliter per minute. So because at that time I was busy trying to find out how creatinine was changing over age, I wanted to link both these data and my data together. And so to the right, you see the graph of the data that he presented. So the P50 value you can see over there. But what we did a little bit later is making a kind of overview with the data from Pieps, as you can see, which is marked there in blue. Yeah, the data of Pieps. If I go back one slide, you see 2-3 years. P50 is 32, then 38.7. As you can see, if you go to 2-3 years, 32, 38.7, exactly the same data. But Pieps also published data from children younger than 2 years. We will not focus on that because that's a very difficult part of the lifespan, let us say. But what we did actually is we used our data, our creatinine data from our local hospital in Kortrijk, all enzymatic, so IDMS traceable. And we also calculated median creatinine values or mean creatinine values for healthy children. So you see next to the left of the GFR 50, which is the median GFR expressed in milliliter per minute, you see the creatinine values. And to the left of that, you see L50 and W50. These are the height of the children and the weight of the children. They're coming from the growth curves of Flanders, children of Flanders, the growth curves. So you can say it's kind of metadata with which we all brought together. And of course, if you have the height and the weight, you can calculate the body surface area. And with the body surface area, you can index GFR with body surface area. And so you can express it in milliliter per minute per 1.73 square meters. And if you then plot this against age, then you see the figure to the right here, and you see that this levels off at about 107.3, explaining immediately already the leading coefficient in the EKFC equation. So that's where the 107.3 comes from actually children data. So now you will ask yourself, of course, but how come that it is used for adults? So let's go a little bit further. And if you see to the left, it's the same figure, the same graph of GFR against age. But also you see it to the right, creatinine as a function of age for children from, let us say, 1 month to about 14 years of age. The middle curve actually is the median creatinine. And you see that there is a linear increase in creatinine with age for children between 1 month and 14 years. And boys and girls, so the boys are the solid circles, that the girls are the open circles, as you can see. They're more or less the same, so there is no difference between boys and girls. The GFR, as I said, is about 107.3 for children between 2 and 14 years old. Creatinine linearly increases with age for children between 2 and 14 years old. And if we assume now that creatinine and GFR are inversely related, then the question is, how can we make an equation that predicts GFR from creatinine, knowing that the behavior is quite different? So normally what would a statistician do? He would try to do regression analysis. And of course, because it's inversely related, he would regress the logarithm of GFR against the logarithm of creatinine and age and probably, but here it's not important, sex, but that will be important later on. Anyhow, we have chosen for another option. And the option is that we rescaled or normalized creatinine using the median serum creatinine value of healthy children. So if you have an individual child, you divide this creatinine value with the median creatinine value, which is related to his or her age. So we still assume that the median GFR of the average of the ideal healthy children will correspond with the median serum creatinine of healthy children. So that's the assumption that we made. And after rescaling, and here you see as an example, a histogram of the data of children we had for 7 to 8 years. So you see it's more or less Gaussian, normal, let us say. And you see that the mean is around 0.44, 0045. So if you divide every individual creatinine value by this median, you get a new histogram. In fact, the shape is exactly the same, but now the mean or the peak is located at 1 because you have divided every individual value by the mean value. So meaning that if serum creatinine divided by Q is equal to 1, you are at the mid. So you should be at 107.3 for GFR. So assuming an inverse relationship, you get this equation, 107.3 divided by this rescaled or normalized creatinine. And the Q value, well, these are the means. These, in fact, as you can see, these are the Q values here in the middle curve. And you can make a linear equation for the Q values. This equation has, of course, been published, has been validated, not only by us, but by other people. And it found, and the advantage of this equation is that if you relate the Q to age, you don't need height. And height is usually not available in the clinical laboratory database. So you can report creatinine, and along with creatinine, you can report immediately eGFR based on that formula, because you don't need height. So it can be reported by the laboratory. That's a big advantage, and that's why this equation was getting was picked up by the pediatric nephrologists. So look here at the distribution of, if you do that, if you normalize or rescale creatinine, and this is done in 8,505 children, right, with the corresponding age-related Q value, then you see that you get a very nice distribution, peaked at 1. And something that is also interesting to observe is that the 2.5th percentile is around 0.67, and the upper is about 1.33. And this actually works for all children, but not only for children. It also works for adolescents, for young adults, and for adults. So if you fill in the data of the previous slide in this formula, you get a distribution like this, peaked at around 107.3, of course, right? So what are these Q values? But these Q values are nothing more than the median creatinine values for healthy populations. And for children aged from 2 to 14 years, they can be modeled as a linear equation of age, but also of height. If you want, you can do it by, you can model them as a function of height. So therefore, you may have an equation, let us say eGFR is 107.3 divided by creatinine divided by Q, which can be age-based. And the advantage is that as height is not available in the clinical lab database, you can report it along with serum creatinine. Or you can also make a height-based equation of it. And then this equation is very equivalent to the bedside Schwarz equation, which is maybe known by you, right? But certainly known by pediatric nephrologists. How do you do that? Well, very simple. Suppose you have, I take my table again. Suppose you have a child of 4 to 5 years old, and you want to calculate the eGFR, then you do 107.3 divided by the creatinine of that child, divided by the corresponding median creatinine, 0.36. So which is age-based? Of course, if you want, if that child by accident would be very tall, and suppose it is 132 centimeters tall, then maybe it would be better not to use 0.36, which is the age related Q value, but you can use 0.47, which is the height related Q value. So these are the two possibilities. You can have a Q age and a Q height equation. Now, we ended at 14 years. And the next question was, of course, what about older children? What about children 14 to 18 years? Adolescents, let us say. Well, actually, this can still be used. And the only thing you have to do is to extend the curve. So you have median creatinine as a function of age. And you see that this curve is nearly linear up to 14 years of age, but then it splits up. There is a kind of acceleration in creatinine generation in boys and not in girls. So that means that you have to use this curve here for boys, and you have to use this curve for girls for the Q value. We have modeled them as polynomials, 4-degree polynomials. This is, of course, somewhere in the software you can put that, and that's easy. You don't have to bother with that. What about the relation with height? Well, actually, this is the relationship between median creatinine and height. And you see here, if you look close, you see circles and you see squares. The squares are the girls, the circles are the boys. Here, they're only boys. That's because the girls, let us say, stop growing around 168 or 170 centimeters, and the boys can be taller. But the curve, there is only one curve. So indeed, you have one curve, one relationship between median creatinine and height. You can still use, of course, this relationship to predict the eGFR from this simple, very simple pediatric equation. So what do we have? We have this simple equation, 107.3 divided by creatinine divided by Q. The Q value can be modeled in children from 2 to 14 years as a linear equation. But if you want to model them from 2 to 18 years, you can use the polynomials. But we also found, and I will show you that, well, actually, we got a data set from Lyon to validate our equation. And the data set they sent us was actually for children of 10 years until young adults of 25 years. So we did not ask for these children or for these young adults, but they gave us the data and we applied this equation and found that it worked. So it worked also for young adults. And then, of course, the question was, could this simple equation also be used for adults aged older than 25 years? And where does it end? So actually, what do we have here? And I show you some data afterwards. This data is not, so the bullets are all children, GFR, measured GFR data of children that we collected during the last 10 years, let us say. So these are children with a normal but also abnormal GFR. And you see the green line, and the green line is 107.3. We got a data set from Lyon, and we could add the data of young adults, where we still have this 107.3 milliliter per minute per 1.73 square meters. Then, of course, we asked ourselves, yeah, but can we? How far can we go? And then we got into contact with Elke Schäfner and Nathalie Ebert from Berlin, who had done the BIS study, and they shared their data with us. And this is the BIS data. So if you look at the BIS data and the BIS equation, of course, which I remodeled in a certain form, then you can see that there is a decline in GFR in older people. Now the question is, how can you connect both? Well, by extrapolating both, you get this. And you see that there is a kind of cutoff at 40 years. So that's the reason why in the EKFC equation, you see this cutoff of 40 years. So what we say is that on average, in a healthy population, GFR remains constant around 107.3, but at the age of 40, natural decline starts due to natural senescence. So you get a decline, and the overall equation can be written in a certain form. And here I added kidney donor data. The blue dots are the kidney donor data, and you see they nicely fit in between. So altogether, you can say GFR is 107.3. Let us say from maturation of the kidneys at 2 years until the age of 40 years. And after 40 years, there is a decline, which we modeled with the factor 0.99 to the power of h minus 40. So actually, if h is 40, you get 0.99 to the power of 0. Mathematically, this is equal to 1. So an important aspect of this equation is that you get continuity across the whole age range. And so you don't need two equations. You don't need, like the Americans, an equation for children and an equation for adults, which shows implausible jumps at the transition between pediatric nephrology and adult nephrology. Jumps that are, let us say, from 80 to 120. You get the present at your birthday of 50% in GFR with the American equations. That's true. I'm not joking. The question, of course, is now, yeah, okay, but this is GFR in general. How do you now still take into account the fact that creatinine can change? And well, actually, you can simply divide this by creatinine divided by Q, still this equation. And then you arrive at the FAS equation. You probably heard about the FAS, the full age spectrum equation. And if you didn't, no problem, because we modified it a little bit, and that became the EKFC equation. So let us say that what I want to resume a little bit, the relationship between GFR and creatinine. We assume an inverse relationship between GFR and creatinine. We aim at one equation applicable for all ages. That means that we require continuity across the full age range. That's not easy because the creatinine age pattern is very different from the GFR age pattern. Actually, what you see is that in children between 1 and 14 years, you have a linear increase in creatinine of age, with age, not different than boys and girls. But between 14 and 18 years, you get a steeper increase, an acceleration, let us say, in creatinine generation in adolescent boys compared to girls. Between 18 and 50, the average creatinine remains relatively, and I'm always talking about the average healthy person. The creatinine equals 0.70 milligram per deciliter for women and 0.90 milligram per deciliter for men. There is a slight increase beyond the age of 50 years. Actually, this is something that I already published in 2008, very closely after the article of Pieps with the measured GFR in children. But this is what you see here, and you should look at the middle curve because the lower and upper curve are the reference intervals. But you see here the increase linear increase until 14 years in males, and then there is an acceleration. Then it goes like this, flat, around 0.9 milligram per deciliter, and then there is a slight increase. And for females, it's the same, but there is not that real acceleration as you can see in boys here, and it remains flat around 0.7, and then there is a slight increase. So what we have is this. This is a nice overview. These are what we call the creatinine growth curves. We called it the creatinine growth curves because they show how creatinine changes with age, in children during growth, and of course during adulthood, and then when you get a little bit older, around 50, 60 years, it starts to increase a little bit. Now, if you normalize every individual value by these curves, of course, these curves become this flat curve, serum creatinine divided by Q equal to 1. And this is the reference interval for serum creatinine divided by Q. Actually, it works for children, it works for adolescents, it works for adults, and it works for older adults. This is what we know about GFR and how GFR evolves with age, right? Now we have to connect this one with this one. So the upper right graph, we have to connect with the lower or the bottom left graph, assuming an inverse relationship. And we got this equation. And you see that I here entered alpha. Actually, this should be written as beta because alpha is not the same here as here. Well, actually, it's the same, but it's not the same when creatinine divided by Q is below 1 or when it is above 1. So this equation is what we call the EKFC equation. And where do these alphas come from? Well, they come from regression analysis. That's the new thing that we entered. After the phase, we have seen that there were some flaws, especially when creatinine was very low. Then we got an overestimation of GFR, and we corrected that by introducing this alpha value, which we had to determine using regression analysis. I don't want to bother you with the mathematics behind that, but this is actually the equation. So the 107.3, you know where it comes from now. The 0.99 to the power of h minus 40, and the reason why it's 40, you know where it comes from. Actually, this is the inverse relationship with creatinine divided by Q. So the rescaled creatinine, and these are the values that we have chosen. Now, the interesting thing is that we now have an equation, a creatinine-based equation, which has been published in Annals of Internal Medicine in 2020. So let's say 2-3 years ago. This is the equation, which we are working on an app, for an internet app, to make it easier for the nephrologist. But you know, this equation actually is of this form. So the EKFC equation is 107.3 divided by creatinine divided by Q to the power of alpha times 0.99 to the power of h minus 40 if h is above 40 years. And I here replaced serum creatinine by biomarker because we believe that the biomarker can be any biomarker. It can be creatinine, it can be cystatin C, it can be beta trace protein, can be any biomarker on the condition that it is appropriately scaled. And creatinine has to be scaled in a different way than cystatin C. So, and beta trace protein probably as well. We haven't done, well, there is actually with the phase 1 publication on the data of the BIS data, so the Berlin data, where we also show that it works for beta trace protein, but this is not the topic of today. We will focus on cystatin C, which is, of course, the topic of our New England Journal of Medicine paper, where the title is Cystatin C-based equation to estimate GFR without the inclusion of race and sex. Actually, it's this form of equation, but the scaling factor is different than for creatinine. And I now leave it to Pierre to tell you more about this.
So thank you very much, Gunnar and Dominique, for this kind invitation. So I will try to summarize the result of this article published in the New England some weeks ago. So first of all, with Hans, we have to thank all the colleagues for the great collaboration, and because of course we can do such an article alone. And you see that we have collaboration from Europe, but also some data from US. And I am particularly proud to say that we have also some data, and it was relatively difficult to do, but they succeed from Africa, from Côte d'Ivoire and from Congo. So the first step was, as Hans just told you, to know the Q value for the cystatin C. And the first idea was to see how we can model cystatin C according to age. And for this point, we were lucky to know that in Sweden, cystatin C is daily practice actually. So they measure cystatin C and creatinine at the same level, at the same frequency, I would say. So we have a large data of lab data. We can say maybe metadata also from Sweden. And so we can do the same as Hans did for the creatinine. So to see how cystatin C is evolving with age. And in this article, we focus only on adults, because the way cystatin C is evolving in children and adolescents is a bit more complex, and probably it will be the next publication. But here we only focus on adults. And what you can see here is clearly after, I would say, 50 years old, a difference in the association between cystatin C and age. And you can see here the way Hans has modeled this association, once again with polynomial regression association. I'm not an expert, but you see what he can find, this type of association with age. And what you can see here is the difference between males and females. And clearly there is a difference between cystatin C value in LC population between males and females. But the difference here, 0.79 and 86, was much less important than for creatinine. So the idea was to fix only one Q value, both for male and females. And you see this Q value for cystatin C is 0.83. And once again, we applied a correction, I would say, for age. And I won't show you the result, but you can see it in the supplement of the New England. When you apply the Q value without independent of sex, because this is the same Q value for males and female, or the different Q value for male and female, you don't lose performance of the EKFC equation, or not too much. So the third step was to know if cystatin C was independent on race, because it was a hot topic, especially in the US, and as you know. So the idea, because we don't have large database of cystatin C in LC Black population, so we take another strategy. And we had data from the same center, actually from Paris. So the same center with the same reference method for measuring GFR, it was Chromoditier for this center, and the same standardized creatinine cystatin C assay with data from Black people and in white people from Paris. And you can see here, of course, that the white and the Black men and the white and Black women did not share exactly the same variables and the same characteristics. So of course, what we did, it's a match analysis. Okay, so we match the analysis and we can find more than 370 match result for age, for BMI, and for eGFR, as you can see here, and for sex, of course. And we can see, and you see here the number of matching results. And of course, when you match, there is no difference in age, no difference in BMI, and no difference in eGFR, of course. And you can see that there is no difference in cystatin C value in this population, whereas there is a very relevant difference in serum creatinine, which is already known, that serum creatinine is not the same between Black and white people. You don't know why, but there is a difference. And this is exactly the same result expressed in the graph. You see here the serum cystatin C, the measured GFR in white men and black men, and you see no difference in the curve, and the same for women. And if you consider serum creatinine, the same graph, you see a clear difference between the two curves. So cystatin C, we confirm by these analyses that cystatin C is independent of race. Race, I use the word race, which is a bit questionable, but we consider race in the American way of thinking. I mean, this is the social difference. Of course, we don't think that race does exist from a biological point of view. So the fourth step was the validation of the new equation. And as Anne says, it's very important to consider the fact that the equation is actually the same for creatinine and cystatin C. But of course, the Q value is not the same. And I showed you before the way we established the Q value for cystatin C. But the equation, the shape of the equation is exactly the same. So these are the different cohorts that have been included in the analysis. You see, we divide it in, I would say, white European, white American, and black from Africa, and black from Europe. And you see also that the different there were different methods for measuring GFR. But in Europe, actually, most of the data were obtained with higher exalt plasma clearance, and also in Africa, which is actually the most used reference method in Europe currently. I'll just show you these two cohorts, because these two cohorts are the external validation cohort of the EKFC paper with creatinine, published in the Annals of Internal Medicine. It's important because we did a sub-analysis. I have no time to show you the results, but we did a sub-analysis in these two cohorts, external validation cohort, which are, once again, not used for the development of the EKFC creatinine equation. But the results are globally the same. So just a few words about statistics. When you want to study the performance of an equation, you compare the equation with the reference, and the reference is measured GFR, of course. You can calculate the correlation, but this is totally insufficient. You have to consider the bias, and the bias is the median difference between the two values, between eGFR and measured GFR. You have to consider precision. The precision is the interquartile range around the bias, and it is the random error. And we use in eGFR topic a metric that we are the only one to use. It's accuracy within 30%. And accuracy within 30% is the percentage of eGFR between plus or minus 30% of measured GFR. And you see, for an example, it's purely theoretical, but you see this method is biased because all the results are higher than the measured GFR, or lower. And this method is unbiased because the bias is zero, close to zero, because the result underestimating are compensated by the result overestimating, but you see that the precision is very low, okay? In the article, it's important to have both bias and precision. And sometimes some authors, they are focusing on bias. And bias is very important from an epidemiological point of view, because if you have an equation which is underestimating GFR, for example, you will overestimate the CKD prevalence in the population, okay? So it's very important at the population point of view. But on the other side, the bias, finally, it's relatively easy to correct. When you have a systematic bias, you can correct it relatively easy. But the precision is also very, very important, especially at the individual level, because the precision, you can correct it easily. And at the individual levels, when you have such a big imprecision, it's impossible to predict where your patient in front of you is, of course, with such a diversion of wide dispersion of the data. So precision is also very important. And the better precision, the lower the IQR. So I show you here the Q creatinine that we use, because we believe that the creatinine should be adapted not to race for us. It's not about the skin color of the race, but about the population. And we show in a previous article that we have different Q value according to a different population. Hans has already shown you the Q value for the white creatinine, the creatinine Q value for the European white Europeans, and we found in European black cohort and in African cohort a slightly different Q value, especially for men, more than for you women. So we compare the CKDP, the EKFC equation, the EKFC Cystatin C equation with the CKDP equation based on creatinine published in 2009 and the new equation published in 2021. You know, the race-free equation based on creatinine. We also compare with the CKDP Cystatin C equation published by the Americans, and also the CKDP combining both creatinine and cystatin C. So in the European cohort, you see when you compare the creatinine, serum creatinine-based equation, clearly the bias was the lowest for the EKFC equation. The precision was the best for the EKFC equation, and the accuracy within 30% was the best with the EKFC equation. And the difference is especially important comparing to the new race-free CKDP equation. With the cystatin C, you can see the EKFC cystatin C equation has also better global performance than compared to the CKDP cystatin C equation. And then when we compare EKFC cystatin C with EKFC creatinine and CKDP creatinine with CKD cystatin C, globally you can see that the difference are not so important. So basically, the performance of the cystatin C equation are not much better than the corresponding creatinine-based equation. But at least we have less variables in the EKFC equation, of course, because we don't have race and we don't have sex. This is globally the same story in the white patient, white subject in Paris cohort. Once again, even if the bias is relatively good for the 2009 with the race equation, CKDP equation, compared to the EKFC, you see that the accuracy within 30% is always better for the EKFC equation, and the precision, once again, is better for the EKFC equation. The same for the EKFC cystatin C, without sex and without race, once again, better than the EKFC cystatin C equation. And once again, the same story when you compare creatinine and cystatin C corresponding equation. So the same picture once again in US white population. This is a limitation of our article. We don't have at this time data in black US population. And you see that the EKFC equation is better than the CKDP equation. Once again, especially if you compare with the race-free, no recommended by the Americans CKDP equation. And you see also a better result for EKFC cystatin C. And once again, always the same story here, more or less the same results between creatinine and cystatin C. In Africa, you see that the EKFC equation is relatively good once again compared to the CKDP equation. A very important point that we have shown before is that the fact that when you use the 2009 equation with the race coefficient in Africa, the equation is performing very poorly. And you see also that the EKFC cystatin C is better than the CKDP cystatin C. And this is probably the only population where there is maybe an advantage of cystatin C compared to creatinine. And this is difficult because cystatin C is not available in Africa, as you know. So it's problematic. But you see that the global performance of the creatinine-based equation in Africa cohort, and this is confirmed by other cohorts published recently in Africa, are really very, very poor. Oh, sorry, I make a mistake. It was the black. This is the African population. Sorry, and you see once again, as I said before, the performance of creatine-based equation is very poor in Africa compared to Europe. And you see here a relatively clear added value of the cystatin C-based equation of the EKFC, especially compared to the creatinine equation, with a P30, which is much better than the P30 with the creatinine-based equation, whatever the creatinine equation in African cohort. So I won't go into the details in this busy table, but just to show you the comparison between the combined equation, EKFC equation and CKD-AP equation. And you see that with the EKFC combining creatinine and cystatin, actually this is the median of the two results. You see that we can reach a P30 of 90%, which is probably the best result you can have with an estimating equation. And this is true in all the cohort, except once again in Africa, probably because eGFR based on the creatinine is so poor in the African cohort that the combined equation could not be better than that. But I will try to show you the same results, but in the pool analysis, so all the subjects together, and I show you here the bias and the P30 according to age. This is a comparison of serum creatinine equation, the CKD-AP, and the EKFC equation. And you see the bias, the gray zone is plus or minus 5 milliliters of bias, which we consider as relatively good bias. It's a bit arbitrary to choose the 5 ml limits, but okay. But what you can see here clearly with it is the race-free CKD-AP equation. First of all, clearly, this equation is biased in most of the population, especially in white Europeans. But you see here that this equation is performing very poorly in young people. And the reason is because, as Hans explained you, the way the model age in the EKFC equation is probably erroneous. And this is the same in terms of P30, with a good P30 largely over 75% for the KFC compared to, once again, a poor performance of the CKD-AP equation in the young and in the elderly people. Comparison of the Cystatin C equation, CKD-AP in black and EKFC in red. The bias is, I would say, relatively the same, but the performance in terms of accuracy is better for EKFC Cystatin C compared to the CKD-AP Cystatin C, keeping in mind that we have less variable because sex or gender is not in our equation. The combined equation, once again, the same picture, you see that the bias and the P30 is better for the EKFC combined equation compared to the CKD-AP combined equation in the pooled cohort. When you mixed all the results, you can have this graph that you can find in the main paper. And I just show you here the result according to eGFR to show you very rapidly that when you compare EKFC with CKD-AP based on creatinine in green or based of the combined equation in blue, you see that the better performance of EKFC is observed in quite all population if the eGFR is below 60 or if eGFR is over 60 in men and women and whatever the age. So the conclusion is that Cystatin C allow GFR estimation without sex and without the race variables. It's very important to keep in mind the EKFC Cystatin C equation is the same generic equation, and of course only the Q value change. As Hans told you before, there is a continuum on the whole age range for the EKFC creatinine, and we are working on the same type of analysis in pediatric, adolescent, young adults with Cystatin C. Globally, Cystatin C based equation are not much better than creatinine-based equation, except maybe in the context in African cohorts. EKFC equation are better than CKD-AP equation, so at least in Europe, I think that this equation is a good alternative to the CKD-AP equation, especially if we compare the results with the new race-free creatinine CKD-AP equation, creatinine-based CKD-AP equation, and this is also observed for the CKDP equation and for the EKFC equation, we gain a bit of accuracy, not a bit, it's a huge improvement actually of 5 and 10% when using the combined equation. Thank you, and I just take the opportunity, if some French-speaking people in the audience, that we are organizing the next French-speaking Congress of Nephrology, Dialysis and Transplantation in Liège, in Leuven. So, and we will organize with Gunnar and Dominique a joint session with between the German and the French-speaking Society of Nephrology.
Thank you very much to both of you. These are great presentations, and congratulations for this great article you just published in the New England Journal of Medicine. I'd like to take you back to baseline considerations for nephrologists that are not really into these formulas. Could you just tell us a bit more about Cystatin C? It's nothing new actually, but it's not very used. I must admit that myself, I very seldom prescribe Cystatin C to estimate GFR. What is the percentage of nephrologists in European countries that use it? And what are the limitations to the fact that we could use it in our everyday practice in terms of price in the different countries?
Clearly, the Cystatin C, the history of the Cystatin C begins in 1885. Anders Group from Sweden is the father of the Cystatin C, I would say. And since then, there are many articles about Cystatin C. And basically, as we show, Cystatin C is not clearly better than creatinine to estimate GFR, but at least we need less variables to estimate GFR. That's very clear. Another very important point for Cystatin C is that probably it's better predict outcomes, and notably cardiovascular outcome, compared to creatinine. So there is, to the best of my knowledge, there is only one country where Cystatin C is used for everybody in every situation. This is Sweden. Okay. And for example, in Belgium, it's still not a daily practice. Why? There are two main reasons. First is the cost. This is still much more costly than creatinine, and probably it will remain more costly because you need for antibodies to measure Cystatin C currently, and so antibodies are more costly than a colorimetric reaction like for creatinine. But still, I think that we can hope, if Cystatin C is more and more used in the world, like for all, the prices will decrease. I think that we can hope that a price of €2 could be reasonable. But today, some labs, you pay sometimes €20 for Cystatin C results. But I think that we can hope for a price decreasing at least to €2, which is still 10 times higher than for the cost of creatinine, for sure. The second limitation is some problems in the standardization, the calibration of the measurement. Okay, like we had with creatinine in the last decades. No, it's relatively solved for creatinine. There are more and more improvement in the standardization of Cystatin C. All the data we used were standardized Cystatin C. So yes, this is the two main limitations. But you know, probably I think that the Cystatin C will be more and more used in US for societal reasons, as I explained you, because it's totally race independent. And you know, if it is used in US, probably we will follow.
Okay, and this leads me to my second question, if I may, Gunnar. You showed us very nicely that the EKFC formula has quite a few advantages over the CKD-EP, and notably over the last one. My question is, how do you think this could be implemented in the guidelines in the future? Because I suppose there are potential lobbies that will influence one or the other formula. And the other thing is that it's very complicated as a general practitioner to implement different formulas frequently. So we're still happy that they have the CKD-EP that it is more broadly used than MDRD and Cockcroft, and this was already a fight. And so changing the formulas regularly is quite complicated in practice, in the everyday practice. So how do you think this will evolve in terms of guidelines and into the practice? Do you think it could change things? How much time it would take? Or if other formulas will come and take over? What will this give in our daily practice?
And this is a difficult question, Dominique, because it's not so difficult to change. Actually, it's just you just ask the laboratory to change the equation in the files. So it's not difficult. It's not very difficult because once again, it's just an equation actually. It's a mathematical model. So it's not difficult to do, not at all. But of course, when you change something in a labs or you change something in an hospital, it's always a bit perturbating for the clinician, of course. But what can I say? I can just say that we did the job. Then it's not in our hand anymore. And for sure, I'm not paranoiac, but the place of the American colleagues and of the CKD-EP authors, I would say, in the CADIGO, for example, is they are very well implemented in the CADIGO. So, okay. But we have also some representatives of the EKFC in the CADIGO, so it will be discussed by the CADIGO, and you know that they are discussing the new equation, the new definition of CKD right now.
Yeah, and I can add that the transition between the pediatric formula, the American pediatric formula, and the CKD-EP equation is really a touchy point because of the very implausible jump that you get if you go from one formula to another formula. So another advantage of our formulas is that they are applicable to the complete age range. So I hope indeed this, together with the fact that Cystatin C equation is race and sex independent, because sex is another issue that is upcoming. Some people don't want to say if they are male or female, and so this equation can also be used, of course, for people that don't want to say this. And this, together with the presence of some people that are co-authors in our New England Journal of Medicine, the presence in the guideline committee, this may help, I hope, to get an entrance in the guidelines.
Yeah, of course, this age problem is a major thing, and age-adjusted definition of CKD is another big problem you've been working on. Thank you. I don't know if Gunnar or Sarah, you have questions in addition.
I only have one. So, Professor Pottel, you said that there was an internet app coming. When will it come? When can I use it?
Well, actually, I wrote an app in Excel, but this is not an internet app, which can be updated with the Cystatin C equation very quickly. The internet app we're working on, this is a PhD student that do this for free. So I don't have a budget for making this app. So I can't push him because he's not paid for it. But it will come in the next weeks, I think.
So I have 2 or 3 remaining issues. So the first one, obviously, is we are really fascinated by your work, and I think it's really a step forward. But surely there's an issue if we have one equation in Europe, but another equation in the States, which will surely render clinical studies and comparison between studies somewhat more difficult, because I guess we will not really convince our American colleagues to adopt your formula. So do you consider this an issue, or should we just go forward with a European solution and actually ignore the CKD-EP, which surely lost some precision in last year with its novel equation?
Yeah, this is a great comment, of course. We are perfectly aware of that, but for the moment, the new, the recommended equation, so the race-free creatine-based equation, I think is very deleterious for European countries, because this equation is much worse and significantly worse than the previous CKD-EP one. So of course there is difference between American and US and Europe, but for the moment we are losing. If you use the CKD-EP, we are losing. I mean, you understand what I mean? We are losing as a continent, because in our country it performs much less well than before. The other point is that now we were looking to collect some data from US, and so this is the next one of the next project, to see how the EKFC could work in America, in American cohorts. And so the first step was to establish Q value, of course, in American people, in American white population, black population. We have such data, and we have the Q value. We can even consider, because the American, they don't want to use race at all, and we can. Our idea is very simple, actually, is to use a median Q value, the median Q value of black and white population. And between you and me, this is exactly what they did with the CKD-EP race-free equation. It's a mix of the two previous equations. But okay, so, and we will test with the Q value how it performs in American cohorts. I don't tell you that they will be convinced by the analysis, but at least we will do it.
So we should try to bring them to step back from that 2021 equation and
they want from the, I mean, with all the race problems, I would say, they won't go back to the 2009 equation. They want, for political, social reasons. And I don't criticize the reasons, but this is a fact. They won't go back to the previous equation. Never. The game is over.
How sure are we that these equations also work in Asian people? Because both European and US American studies surely focused upon either white or Afro-American or black people. There are rather few Asian people included, even though the majority of people on Earth are actually Asian people. So are there any concerns from your side that you would see the need to do further work in Asian people, or could we just go ahead?
No, this is very important. I think that all the data that we have for the moment in the literature show that all equations are probably worse in Asian people. At least the CKD-EP equation. If you use the CKD equation as it is, I mean, the results in Asian population, it's horrible. It's terrible. The performance is terribly low. But once again, the EKFC equation has not been tested, but you can, or very fewly tested, some paper. But if you can imagine that even with the creatine-based equation, if we establish the Q value in Asian population, maybe we can expect, at least theoretically, a better performance of the EKFC equation. Need to be tested. And of course, also Cystatin C is very important for Asia, I think, because once again, probably Cystatin C is also independent of race, I would say, of population, including in Asia, and probably it will be a very good point also for Asia, because once again, when you see the global performance in Japan, in China of the CKD-EP equation, the accuracy within 30% is less than 70%. In most of the publication, less than 70%. This is terrible. So probably Cystatin C is useful, and maybe once again, maybe the EKFC could be of interest.
There is also a very recent study in Korea comparing the original 2009 CKD-EP equation with the 2021 CKD-EP equation with our EKFC creatinine-based equation. And it shows that our equation is performing better than the other two. So this is in Asia, and they used the Caucasian, so Q values. So it can probably even be fine-tuned by using local population-based Q values, Korean-based Q values.
we had a talk with Elke Schäffner, and she recommended us to measure GFR more often rather than just always estimating. That's something which is seldom done in clinical practice. Do you see the need to do more measurements on GFR with whichever technique available, or should we really focus upon the estimation?
No, clearly, I think that I totally agree with Elke. Measuring GFR should be more and more frequently done in clinical practice, at least for nephrologists. It is a reference method. We must keep in mind that the goal of estimating GFR, as I show you, is an accuracy of 30%. But that means if we take a simple number of 100 ml per minute of measured GFR, that means that we accept as a good estimator an estimation giving a result between 17 and 130. That's what we accept. Okay. 70 to 130. This is quite a wide range of acceptance. And if you want to be more precise, I mean accuracy within 10%, then all equations are failing.
Mm-hmm.
All equations are failing. So it depends of the context. We don't need for a precise GFR in all patients, including in nephrology. But I think that sometimes in specific situation and in specific patient, because once again, all these equations, they are not magic. If, for example, creatinine, you think that your creatinine result is not good for your patient, most of the time because the patient has abnormal muscular mass, for example, there is absolutely no reason that the equation, because you put the creatinine result in an equation, the result will become good. This is not magic. Creatinine is the main variable in all equations. So in some population, in some patient, we need for measure GFR. And I think that in the future, we will try to better implement the measuring GFR with simplified methods. For the moment, I think that the most simple method is to use ioexol plasma clearance. Of course, it's definitely more costly than creatinine and cystatin C, for sure. But once again, not in every patient you do that. And sometimes and frequently you can read in the literature, oh, it's cumbersome. Yes, of course, it's more difficult than just drawing blood samples and measuring creatinine, but it's not so difficult. Honestly, it's not so difficult. You have very simplified protocols. You can have only one lab per region or per country measuring ioexol. You don't need to have many labs in the country. You can have one central lab measuring ioexol for you. And the methodology is very simple. It's not very complex to do. You inject a few ioexol, and then you take blood samples after 2, 3, 4, and 5 hours. This is not complex. And then you apply a mathematical equation to have the measured GFR. So it's not very difficult.
And surely you need a lab who does this measurement. And I think that's kind of a limitation for many hospitals like our hospital, because our lab would not do this examinations.
At least in Belgium, I don't know what all labs are doing in Germany, but in Belgium it's not difficult because ioexol is very, very stable. Very stable. So you can send your ioexol sample to Brussels from Liège, or the opposite, from Liège to Brussels. It will be good. And the best example is actually the data we have from Congo and Côte d'Ivoire. Of course, and unfortunately, they don't measure ioexol locally. So the ioexol was sent to Belgium. But once again, it's very, very stable. It's a very stable. It's an inert component, ioexol. So it's very stable. It's not there is no degradation in the tube. I mean, so you can easily work with a central laboratory. If you have one laboratory in Germany measuring ioexol, you send all your results to this laboratory, and they will manage. Again, it's not a problem in Belgium. I think in France it would be the same. You can work with some labs, and there are some labs in France, in Paris, in Lyon, measuring ioexol, and you can easily send the sample to them.
So my last question before switching the mic back to Sarah. What about drug dosages? Because we still have for many drugs the Cockcroft-Gault equation as a standard, and there are few efforts being made to give us more modern tools to adopt drug dosage. So how do you see the future of drug dosing here with all these novel equations?
This is a very challenging topic, yeah? Very challenging topic, because you know that, for example, when you talk with some pharmacologists, they still recommend to use the Cockcroft equation, actually, yeah? And they have arguments. I can say that they have arguments to use it. Not in terms of GFR estimation, because definitively the Cockcroft equation is the worst equation to estimate GFR, but they have other arguments. For example, they can say, okay, all the drug dosage for all drugs have been established with Cockcroft, so I use Cockcroft, for example. This is an argument. This is a relevant argument, I'd say. But okay, the fact is that we don't have strong data regarding drug dosage to assert that an equation is better than another one. We don't have strong data. The ideal would be to have a study, a randomized study, two groups, one with drug adaptation with one equation, the other with another equation, and to see if you have more adverse events or if you are more efficient with one equation compared to another one. But such a study does not exist. We have only, I would say, a study comparing the potential drug dose difference between the equation. But it's not real life study, it's just a simulation, I would say. So but such a study is, they are difficult to do, probably. You need to do that multicentric study. And yeah, this is a very challenging topic.
So thanks so much to the both of you. I just wanted to do a little bit of advertisement for our academic Tour de France series. Just like last year, we'll be doing it again this year in July with brand new topics and great specialists. We'll be going from Bordeaux via Limoges to Paris. And we'll be working together with the Société francophone de nephrologie, dialyse et transplantation, with the Deutsche Gesellschaft für Nephrologie, and with the Österreichische Gesellschaft für Nephrologie as academic partners. And we are very happy to have Professor Dominique Guerrot as a co-host. And I hope that a lot of you will participate.
So thanks a lot for being with us tonight. Thanks a lot for doing all this work. And we're looking forward to reading more of you and for seeing the next papers from you. Good night.
Okay, good night. Thank you very much.